Now, the amount of force that is generated is determined by the amount of distance that each sarcomere travels. So, if the heart dilates, the amount of distance that the actin and myosin will have to travel is greater. So, the amount of force that will be generated is more. But then a situation will occur that the heart dilates so much that the actin and myosin, they do not overlap each other. They are completely separated. At that time, contraction will not be possible and it will result in heart failure. So, heart dilatation is a form of a compensatory mechanism to increase, but if the compensatory mechanism is overachieved, then it will result in heart failure. Now, but how do the muscles coordinate that? How do they all contract at the same time and all relax at the same time? This depends upon the specialized intercalated discs and junctions which facilitates the cell-to-cell and the mechanical ionic coupling. In these gaps, they provide a rapid movement of ions, the sodium, potassium and calcium ions between adjoining cells, so that they all transmit the electrical impulse at the same time and cause them to contract at the same time. If there is any abnormality in these ions, it will result in cardiac arrhythmias and heart failure. Now, the energy meets of cardiac myocytes, it is achieved by oxidative phosphorylation. You know there are two types, oxidative and anaerobic also, but in this oxidative phosphorylation occurs, and to achieve this, the cardiac myocytes have a high density of mitochondria. So approximately 20 to 30% of the cell, the cardiac myocyte is made up of mitochondria, and secondly, it requires a constant supply of oxygenated blood. So the myocardium is extremely sensitive to ischemia. Now, the heart is supplied by the coronary arteries, and they arise immediately distal to the aortic valve from the aorta. And initially, they cover a course along the outer surface. So this portion of the cardiac arteries is known as the epicardial artery, and once they pierce the muscle, these are known as the intramural arteries. So the main branches are the left anterior descending, left circumflex and the right coronary arteries. Now, in this we can see that generally the left and the coronary arteries, they are end arteries. That is, though the vessel supply between these two, they do not have any interconnection. But collaterals between the capillaries of both the arteries occur. What is collateral? Collateral means there is junction, some vessels develop between the capillaries of both the right and the left coronary arteries. And these collaterals, these develop as a result of either chronic ischemia or as a result of regular exercises. So this is the importance about regular exercises for development of collaterals. So if there is ischemia in this portion, that is, if this part of lumen is blocked, if the collaterals are there, so the area which is supplied by this portion of the artery, it will be less affected because the part is supplied by the vessel from the next coronary artery. So if collaterals are there, the area affected will be less, while if there are no collaterals here, you can see the area of infarction is much greater. Now, the blood flow to the myocardium, it occurs during the ventricular diastole. So when the other part of the body does not receive the blood, it is the coronary arteries which receive the blood, because at this time the myocardium is relaxed and the microcirculation of the heart is not compressed by the myocardium. And usually at rest, the diastole comprises two-thirds of the cardiac cycle, and therefore when tachycardia occurs due to any cause, it shortens the cardiac cycle and thus shortening the diastole and compromising the oxygenation of cardiac muscles. Now, we come to the today's topic now, ischemic heart disease. So, it represents a group of pathophysiologically related syndromes resulting from myocardial ischemia. And when does myocardial ischemia occurs? No, it's quite late, you can go now. It results due to an imbalance between supply, thank you. It occurs due to imbalance between supply and demand of the oxygenated blood. So either the supply is more or the demand is less. Sorry, I said it wrong. Either the supply is less or the demand is more. Sorry. So what does the ischemia cause? Ischemia limits the tissue oxygenation. That is, ATP generation is less because there is less amount of oxygen. It reduces the availability of the nutrients, other nutrients also, and it hinders the removal of the metabolic waste. Now, so ischemia is different from hypoxia. In hypoxia, there is only limited amount of oxygen, but removal of metabolic waste is there and also nutrients are present. So hypoxia is usually well tolerated than ischemia. Yes, in the center, third. Do you want to talk more? Or if you don't want to listen, you are welcome to go out of the class. So you should know the difference between what is hypoxia and what is ischemia. Hypoxia generally occurs in congenital heart diseases, the cyanotic ones, or it can occur with severe anemia, or it can occur in high altitudes also, where the oxygen concentration of air is low. Now, what is the pathogenesis? In more than 90% cases, the blood supply is less due to progressive atherosclerotic narrowing of the epicardial coronary arteries, and then variable degrees of superimposed plaque and thrombosis. So you can see there is chronic atherosclerosis on this. This chronic may increase and it will cause reduced lumen, or there may be disruption, and then there is a platelet aggregation and then thrombus formation completely occluding the vessel. Now, other causes may be due to coronary emboli, vessel inflammation or spasm. And the cardiac demand, it may be due to the tachycardia, there may be cardiac hypertrophy, hypoxemia and systemic hypotension. When the lumen is 75% obstructed, it is a threshold when the symptoms of hypoxemia, of ischemia will occur by a moderate increase in exercise. So 75% obstruction is the threshold, and when it is 90% obstructed, the symptoms will appear even at rest. However, if ischemia, as we have seen, it develops very slowly, then collaterals will form and will protect against the ischemia and limits the area of infarction. Now, either one epicardial artery or all three may be involved, and usually they are involved within first 3 centimeters, and atherosclerosis of the intramural branches is very rare. Now, what does ischemia, myocardial ischemia can cause? It can cause angina. It may result in these 4 clinical cases: angina, MI, sudden cardiac death, or chronic ischemic heart disease with heart failure. So what is angina pectoris? It is paroxysmal, usually recurrent attacks of pain, and most important, it is caused by a transient myocardial ischemia of less than 15 minutes which is insufficient to cause myocardial necrosis. But pain occurs. Why does the pain occur without necrosis? Pain occurs because of release of bradykinin and adenosine and few molecules that stimulate the sympathetic and the vagal afferent nerves. So there is pain even without necrosis in angina. Now, the angina pectoris may present in three forms: the stable or the typical angina, prinzmetal, and unstable or crescendo. So the stable type is most common, and usually it is due to decreased perfusion, and when there is increased demand in setting of decreased perfusion. That is, there is increased physical activity, emotional excitement, or a psychological stress. And this, the pain is deep, poorly localized, and squeezing or burning like, and it is relieved by rest or by vasodilators. The prinzmetal one, it is uncommon, and usually it is caused by a coronary artery spasm. So it will respond promptly to vasodilators. Then the unstable or the crescendo, this is very frequently occurring pain. When the angina occurs frequently, it will result into unstable type. It is prolonged and it is precipitated by a very low level of exercises. And usually it is caused by a disruption in the atherosclerotic plaque. And in these, usually one half of the patient may have evidence of infarction, or they are very imminent to develop infarction. So you can say it is just a preceding state of myocardial infarction. So myocardial infarction, what is it? It is the death of cardiac myocyte due to prolonged severe ischemia. And in common language, it is referred to as heart attack. And the earliest detectable feature of myocardial necrosis is disruption of the integrity of the sarcolemmal membrane, that is the outer membrane of the cardiac myocyte. When there is disruption, what will happen? The enzymes and proteins that are present in the cytoplasm will come out. These then diffuse into the blood, and these enzymes and protein form the basis of diagnosis of the myocardial infarction by blood test. Okay, this is how the enzymes and the proteins that we detect in blood occur because of disruption in the membrane of the cardiac myocytes. Now, it increases as the age increases. It is more in males in the middle ages. However, postmenopausal, it is increasingly found in the elderly women, and the hormonal replacement therapy is not protective. Now, this occurs due to the occlusion and the myocardial response to ischemia. As in atherosclerosis, we had seen that what is the pathogenesis of atherosclerosis? It is inflammation and the healing response to inflammation. Same way, the myocardial infarction and the consequences of myocardial infarction are a result of occlusion and the response of the body to that occlusion. So the coronary artery occlusion, you have seen it occurs in, first of all, plaque will occur. You had seen the diagram. Then subendothelial collagen is exposed. So platelets will adhere. They will release platelet activating factors. They will call vasospasm. And then tissue factor will also be activated, and it will activate the coagulation pathway. And within minutes, the thrombus will expand and lead to occlusion of the lumen. In 10% cases, there may be some other pathogenesis like vasospasm, which may be with or without platelet aggregation, especially in cases of drug ingestion like cocaine and ephedrine. So there are many cases of heart failure in drug addicts. It is basically due to the vasospasm that occurs due to the drug overdose. Then there may be emboli coming either from the left atrium or paradoxical emboli from the right heart. There may be disorders of small intramural vessels like vasculitis, in sickle cell disease, because the RBCs, they are abnormal shape and they clog the arteries. Then there may be amyloid deposition, there may be vascular dissection, there may be cardiac hypertrophy, or a very important cause, there may be lowered systemic blood pressure or shock. This is also a major cause of ischemia. Then once the blood supply is decreased, it causes ischemia. Ischemia, before it causes death, what does it do? It causes impaired myocardial dysfunction. That is, the myocyte ceases to contract. And so it can cause heart failure before myocyte death. So death may occur due to heart failure before full-fledged infarction can be there. Or if it follows the full procedure, then there will be myocardial dysfunction, and if the ischemia is prolonged, it will cause myocyte death. And this outcome depends on severity of the blockage of the vessel and the time, for how much time the blockage has occurred. So initially what happens when the metabolism, aerobic metabolism gets stopped due to decreased oxygen, so there is no ATP formation. Secondly, there is accumulation of the noxious metabolite, in which lactic acid is the main, and because of both these things, because ATP is not there and lactic acid is there, the myocardial fiber will cease to contract and loss of function will precipitate the heart failure. Then suppose heart failure does not occur and the ischemia continues, there will be ultrastructural changes. First of all, that is, you cannot see with light microscopy, you can only see it with electron microscope. There will be myofibrillar relaxation, glycogen depletion, cell and mitochondrial swelling. However, these all changes, they are reversible. And severe ischemia, if lasting for 20 to 30 minutes, will lead to irreversible damage. So these 20 to 30 minutes is known as the golden period, in which if the patient is taken to the hospital and reperfusion is started, infarction, ischemia of the heart can be prevented. Now, the ischemia, it usually, because the supply is from the epicardial arteries. So the supply of the vessel to the myocardium is from the epicardium to the endocardium. So endocardium is the zone which is the most susceptible to ischemic injury. So when the necrosis starts, it will start from the endocardium to myocardium. This is, and then a transmural infarct will occur. However, a very narrow zone here in the endocardium, this is spared from necrosis because it gets supplied directly from the blood which is present in the chambers. Now, the precise location will depend, as I already told you, the severity, the time, then what are the needs of the myocardium at time. Suppose if the myocardium is at rest, so the demand will be less, so infarction will be less. And at the same time, when this pathology is happening, the patient does exercises, then the demand is also more. So infarction will occur quicker and it will be more severe. And usually the necrosis involves 1/2 of the myocardial thickness in 2 to 3 hours, and it is transmural in 6 hours. However, if there is chronic ischemia where collaterals have developed, the transmural infarction can take as long as 12 hours. So if this is the supply of the coronary arteries, and if we know which coronary artery is blocked, we can predict that which area of the heart will be. Here, shall I continue or not? So the left anterior descending branch of the left coronary artery supplies most of the apex of the heart, anterior wall of the left ventricle, and anterior 2/3 of the ventricular septum. The posterior 1/3 of the ventricular septum may be supplied either by the right coronary or the left circumflex, and whichever supplies is known as the dominant one. And the right coronary artery supplies the entire right ventricular free wall, posterobasal wall, and the posterior 1/3 of the ventricular septum, usually in 80% cases. And the left circumflex supplies the lateral wall of the left ventricle. Now the infarction, as we have seen, it may be transmural, subendocardial, or multifocal. Here you can see the transmural occlusion is due to the occlusion of the epicardial arteries, and it will start from the endocardial zone and it will shift to the epicardium. And in these cases, usually the ECG changes will show an ST elevation. So these are also known as the ST elevation myocardial infarction. While in the subendocardial, these subendocardial may be due to the mild form of atherosclerosis or thrombosis which gets lysed very soon. So the duration of ischemia is less. Or it may be due to systemic hypotension. When systemic hypotension occurs, the blood pressure is very low and the blood supply becomes very low. If it occurs due to systemic hypotension, the infarction will be circumferential. That is, the whole layer of the heart will be involved. And usually in the subendocardial, when necrosis occurs, when ECG is done, there is the ST segment elevation is not present, rather ST depression may be seen. So this is known as non-ST elevation myocardial infarction. There may be also multifocal infarcts. Now these multifocal infarcts may be present due to any form of vasculitis, okay, or if there are some multiple emboli from some area. So these will call multiple small areas of infarction, and this may result in ischemic cardiomyopathy and later on heart failure. Usually the left anterior descending is involved in 40 to 50% cases. The right coronary in 30 to 40% cases, and the left circumflex in 15 to 20% cases. So as we had seen, ultrastructural, there is relaxation of myofibril, glycogen loss, and mitochondrial this thing. Then there occurs the sarcolemmal disruption, due to which enzymes and proteins occur. Here, if the MI precedes 2 to 3 hours before death, and we stain it with tetraphenyl tetrazolium chloride. If we take a section, a slice of the heart, and we stain with tetraphenyl tetrazolium chloride, we'll see that the uninfarcted area is red and the infarcted area is pale, because here the activity of the enzyme LDH, lactate dehydrogenase, is maintained, while in this area the LDH has oozed out from the cell. So there is no enzyme activity and it will appear as a pale area. So after the sarcolemmal disruption and the enzymes are released, what happens? The coagulative necrosis of the fibers start and they get disrupted. So here you can see that the myocardial fibers are arranged in the laminar fashion, and here the necrosis is started, it is more pinkish, and there is depression, there is space between the fibers. After coagulative necrosis, you can see here they are completely necrosed, completely you cannot see any morphology, and in between you can see the inflammatory infiltration. Initially, majority of these are neutrophils, later on lymphocytes and macrophages will also occur. Then here you can see that the dead myocytes, they have been completely phagocytized by macrophages, and all you can see are the inflammatory cells and macrophages. Then there is healing by fibrosis, and you can see small, this blue colored collagen deposition has occurred, and this is the healed scar in which collagen and fibrous tissue has replaced the muscle, and very few muscle fibers you can see in between which have survived the infarction. So the healing infarct, at present it is a non-uniform worm because it starts the vessels from which they get the blood. They are at the periphery. So the healing starts from the periphery. So the healing scar is non-uniform. That is, at the periphery it will be completely healed, while in the center it is yet non-healed. And once it is healed, it is very difficult to determine its age, whether it is of 8 to 10 weeks or whether it is 10-year-old, because it is completely collagenized. Now, how is infarct modified by reperfusion? Why do we say that the reperfusion should be started immediately and it will limit infarction? Because the goal is to salvage the cardiac muscles which is at risk from ischemia. Therefore, prompt reperfusion is the treatment of choice in myocardial infarction. Now, what are the various methods by which it can be done? It can be done by thrombolysis, by administrating medicinal which will cause thrombolysis of the thrombus which is blocking the lumen. It can be done by angioplasty, then angioplasty with stent placement, or it can be done by open surgery of bypass coronary artery bypass graft surgery. Now, what are the benefits? Benefit is, that is, if we re-establish the coronary blood following obstruction, the infarction will be less and there will be restoration of the blood flow. Now, when we reperfuse, usually at a glance it will appear that we have what we have done, because the vascular beds that are present in the infarcted area, they are all leaking. So when we reperfused, the cardiac muscle will appear very hemorrhagic, because whatever blood we are giving, some amount of blood will flow outside. Now, there are some side effects of reperfusion. We cannot avoid reperfusion, but we should be aware that these reperfusion injuries may occur, so we can decide the treatment modalities. Now, this occurs due to the oxidative stress, calcium overload, and the additional amount of inflammatory cells that are recruited after reperfusion. There may be also that when the blood is there, the endothelial cells may become swollen up, so that the lumen of the capillaries is blocked, and even when we have reperfused, the end tissue does not get any blood. That is, becomes a no reflow. Understood? Because the last vessels that are present, the capillaries, the lumen of the capillaries is blocked, so we cannot do anything in that. Now, there is a term, stunned myocardium. This is a physiological terminology, and it is a state of prolonged cardiac failure which is induced by short-term ischemia that recovers after several days. So the biochemical abnormalities will persist for days to weeks. And second term is hibernation. In this myocardium, when it is subjected to sublethal ischemia, that is, ischemia is present, but it is not to the extent that can cause necrosis of the myocytes. It will enter into a state of lowered metabolism, where it will require less amount of oxygen, and if we revascularize, it will restore the function. Now, how can we diagnose MI? We diagnose MI on the basis of the clinical symptoms, lab tests, and the characteristic ECG changes. So the clinical features are chest pain, which is usually prolonged, and the characteristic is it is usually crushing, stabbing or squeezing. The pulse is very weak. There is profuse sweating, known as diaphoresis, and nausea and vomiting may occur if the posterior-inferior ventricle is involved, because this will cause vagal stimulation. Here's the third row. I don't think so you are interested. Are you? This is the third time that I'm asking you to. If I have to ask you again, I'll just mark you absent, all of you. So the nausea and vomiting, they are a sign that there may be involvement of the posterior inferior ventricle, and this causes vagal stimulation. There may be dyspnea due to pulmonary congestion and edema due to the impaired contractility of the ischemic myocardium. Because the myocardium cannot contract properly, it will cause backflow and it will cause pulmonary congestion, which will result in dyspnea. And in 25% cases, it may be asymptomatic, especially in cases of where diabetic neuropathy has occurred. And in these cases, it will be discovered only by ECG changes and lab investigations. Now, the lab investigation that I told you, it is based on the measurement of the proteins and enzymes that have leaked out. And the most useful ones are the troponin TNI, CKMB, and LDH1. So the troponin TNI, these are the proteins that regulate calcium-mediated contraction of the skeletal and the cardiac muscles. They usually begin to rise at 3 to 12 hours, peak at 12 to 48 hours, and troponin T returns to normal in 5 to 14 days, and troponin I returns to normal in 5 to 10 days. Now, creatine kinase, it is enzyme which is expressed in brain, myocardium, and striated muscle, and it is made up of two dimers, M and B. So it may be totally M and M, B and B, or M and B. So the M and M homodimers, these are present in the cardiac and the skeletal muscles. B and B are present in the brain, lungs, and many other tissues. And MB, heterodimer, it is present usually only in the cardiac muscle and a very small amount in the skeletal muscles. So the MB heterodimer is very specific for the heart. And it begins to rise in 3 to 12 hours. That is the earliest rising. Very soon it rises and it peaks at 24 hours and becomes normal in 48 to 72 hours. So if you have to see whether the MI is acute, we'll first of all do the CKMB. Then what are the consequences and complications of MI? The prognosis which affects are the advanced age, the female gender, diabetes mellitus, and if there is any other history of previous MI. So there can be contractile dysfunction, there may be arrhythmias, there may be rupture, there may be aneurysm, pericarditis, there may be the infarct may enlarge, and in the infarcted area there may be development of mural thrombosis in the chamber. There may be papillary muscle dysfunction, or the patient may survive and then he may develop chronic ischemic heart disease. So due to the infarct, there is some ventricular dysfunction, and because of the left ventricular failure, there is hypotension. And I've told you pulmonary congestion leading to edema and respiratory impairment. If there is severe pump failure, this is known as a cardiogenic shock. And this occurs when more than 40% of the ventricular area is involved, and it has nearly 70% mortality rate. And the right ventricular infarcts can cause right heart failure. Then arrhythmia occurs because after MI there is myocardial irritability, because the electrical impulses that they follow off path because of the infarction in between, they cannot pass on normally. And especially when the infarct area involves the bundle of his, arrhythmias can occur, which are usually fatal. Then there can be rupture of the ventricular free wall. This will result in hemopericardium and cardiac tamponade. If there is rupture of the ventricular septum, it will cause ventricular septal defect and there will be shunting from the left to the right. If there is a papillary muscle rupture, it will cause mitral regurgitation. Then aneurysm, ventricular aneurysm may occur, and the boundaries of the aneurysm will be the fibrosed ventricular muscles. There may be pericarditis, which is usually fibrinous or fibrinohemorrhagic, and the infarct may enlarge. Mural thrombus may occur, and there may be papillary muscle dysfunction. Now, the chronic ischemic heart disease is used to progress a progressive congestive heart failure as a consequence of accumulated ischemic myocardial damage. Now, there is a term acute coronary syndrome. I have covered all this. In this, there is unstable angina, myocardial infarction, and there is sudden cardiac death. So, I have taken your angina and the myocardial infarction part, and the sudden, in this it is again, if there is transmural, it will cause ECG segment elevation known as the STEMI type of myocardial infarct. If there is subendocardial non-STEMI, and if there are microscopic infarcts, then in ECG you won't find any changes, just a revision. And the sudden cardiac death may arise, usually it arises because of arrhythmias without myocyte necrosis, and second is if there is a very large infarct, I told you, more than 40%, then cardiac shock will follow. So these are the two major causes of death, of sudden cardiac death in ischemia. One is because of arrhythmias and if a large infarct is present. So that's all for today.